What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And I'm Mark. All right, guys. So today what we want to talk about is building on the portion of the exam that we talked about in the last episode, which was the objective exam. We want to evaluate and speak a little bit more about how you take the impairments that you identified in the objective exam and how you're able to identify them, how you're able to measure them, how you're able to reassess them, and how you are able to gauge progress with the patient in regards to their specific impairments. Now, another thing we're going to touch on in terms of our concept of testing and retesting the impairments is which impairments we feel like have the most value when it comes to retest. And when we say most value, we mean in terms of if you're able to change one, which ones have maybe the highest or the best prognostic value, and then which are, maybe are still helpful to retest, but maybe fall a little bit on the, lower end of that hierarchy. So Kane, we talked about measuring impairments in the previous episode. We talked about how we do so. When you identify a specific impairment, are there any specific ways that you're looking to, continually, we'll say, like reassess them? How are you, identifying them, and how are you tracking it over time?
So I guess one of the big ones that I usually do when it comes to identifying impairments is making sure that it's relevant to the patient first. So if they are struggling to do an activity because they can't reach a certain point, like a really common one is like, I can't fasten my bra, or I can't tuck my shirt in, I can't put my belt into my on my pants, or I can't bend forward to tie my shoes, things along those lines, because those are activities that if they're able to do, and if they're limited by their range of motion, and that's gradually improving, they'll probably say, I can do this easier now, or we're making progress here. So what I usually try to do is I have my patients come with a list of things. And even on the first exam where they come in, they're, I don't know, it just kind of happens randomly. I usually send them home with more homework to try to figure out and find more tasks that they are struggling to do. Because in the beginning, you try to knock off the simplest one, the easiest one, and over time, as that starts to get better, you move on to the next task, and so on and so forth. Sometimes you can only find one at that time, and then eventually the patient's like, I started doing more, and now I'm noticing that this is still an issue, or that I can't do this. So it just gives you more things to kind of check off that are relevant to the patient and their impairment. Those are the main heavy hitters that I use to make sure that we're on the same page in regards to getting them better care. For my own sake, I usually just do like a quick visual assessment. Like, is their isolated range getting better? Is their functional range getting better? And you can usually compare from one session to the other. And I think that makes it a whole lot easier to actually know whether or not you're moving in the right direction, compared to if you just get their baseline on eval, you check it again on re-eval. Within that time frame, you could have lost a whole lot of time going in the wrong direction. So that's why I consistently will always check in, making sure like, hey, how's this going for you at home? You complained about it before. Is it getting any better? Anything along the lines of that. That's typically how I would approach things, just by making it a lot more pertinent and salient to the patient. What about for you?
Yeah, gotcha.
What's your go-to?
Yeah, I do something similar for sure. I mean, I definitely agree with what you talked about. Like, you have a functional component, and also I think having a measurable, we can just say like impairment based, something you can research as a range of motion or strength, something like that. That's something that, from our perspective, we can easily use to get an idea as if we're heading in the right direction or not. Yeah, so I do a similar thing. I definitely am asking and like them, what or do you find you're limited with your day to day or work related tasks, something like that. So that's something easily they can show me. Yeah, reaching overhead, behind the back, like you mentioned. But then also getting, you know, I find that typically if someone's coming in, one of the main impairments I try to assess. I mean, it's simple, it's easy, but also at least from my perspective, when it comes to the value or prognostically, if you're able to change their range of motion or the pain they have with range of motion, especially if they have limited range of motion, I find that has a lot of value. So when I'm going through and I'm looking for impairments, that's something that I try to identify, and it's something that I am consistently trying to reassess as well. And
So
that tip, yeah, go ahead.
I was going to ask, when you're checking their impairments, like for range of motion, for example, do you use, how many times do you use a GONI? Do you just visually assess? Like,
Yeah,
do you
visual.
go
I
based
don't
off a
use the
patient
GONI.
report?
Yeah, because at least in my mind, if someone, let's just use shoulder flexion. Let's say they are able to flex their shoulder to 130 degrees. If they improve by like such a small amount that I'm not able to visually detect it and I have to use a goniometer, to me that's not enough of an improved response that I can say that it's good enough, right? So if we're going from like 130 to 136, right? Yeah, I'm not impressed like that. I'm looking for something that's like 130 to 150, 160, or even more, or normalizing within the session, right? So I don't find the goniometer for me has a lot of value in at least the patient population that we're speaking about. Now, if it's something post-op, get a knee or cuff repair or something, and I'm want to be able to quantify it, yeah, I'll use a goniometer, but that's I guess a different kind of way I'm identifying parents in a different patient population. We're having people coming in with this like acute, subacute, chronic type pain, non-operative. I don't find the goniometer provides me much value, just because when I'm looking for these impairments, we're looking to make a quick, noticeable, relevant change, right? Like, and just getting a couple degrees out of a plane of movement to me doesn't fit that criteria. Do you find that you use other tools to measure range of motion, or do you gauge it a different way?
I pretty much just use like my own visual inspection and the patient's like own report and what their perception is.
Yeah, they'll know if it's better. Like, oh yeah, I haven't, like you talk about reaching behind their back. Oh yeah, now I can touch this part of my back. This, right? I don't think there's, at least if you're trying to get the response that we're going for, the person knows if I think most times the person tells me, oh, I feel like I can move it farther. Yeah, well, yeah, you are, right? They should be able to know on their own.
Yeah, I actually started waiting now instead of giving my own commentary right away.
Mm-hmm.
Because sometimes I'm just, I'm excited and I'll just, that definitely is moving further. It looks better. I'll usually wait and then I'll ask, how does that feel?
Yeah.
And have them give me that actual confirmation instead of me biasing them. So when they say it themselves, that to me is a lot more impactful, and that's a lot more pertinent to the patient, where they're like, oh no, I am actually feeling a change, versus like, even if I measure a change, if they don't feel that change, it's not really important or impactful to them.
Yeah, right. Like, we get those people who, yeah, maybe it's better, but like if you're not changing their perspective on how it felt, then yeah, I don't know how much value it is to the patient, right?
For sure.
Yeah.
I think it's so funny that like going through PT school, I never really put as much emphasis on the importance of someone's range. I just thought, oh, it's not mobile. Okay, so we get to move and that's it. Yeah. Most issues could probably be resolved with like exercise or getting them to move better and blah, blah, blah. But in reality, if a joint's not happy, if it's not moving well, it's going to impact a whole lot of things in their function. So that really changes how I prioritize range of motion in like the list of impairments that I want to be able to hit.
Yeah. I think it may be helpful to clarify too. Like we last episode, this episode, we were talking about these these impairments. We're talking about range of motion, but we're talking about it in a specific context, and within individuals who have limited range of motion. They fit a certain presentation where they have limited range of motion, they have pain that's impacting their function. We're going to talk about how we address it in following episodes, but we're not just talking about someone who, tight muscles, stuff like that. It's a certain clinical presentation that can be addressed, that has a quick response, that can be addressed quickly, and that where reassessment is valuable. But yeah, it is, like you said, it's interesting. It's just like, goniometry, range of motion, you just measure it, and if it's tight, you stretch it out. But we found there's different ways you can approach it where you can change these kind of presentations quickly.
Yeah, I thought it was really interesting that you mentioned that, because there are definitely times where, and just like Mark said, it is a different type of pattern or patient presentation. A lot of times there are also those kinds of patients where you have a limitation in their range of motion, but there's nothing wrong with it. Like their function's totally okay. We're allowed to have asymmetries. Like just because we find something that, like on our exam, it doesn't make it relevant all the time. So we don't have to go and fix everything. Sometimes that just kind of leads it down a rabbit hole. And I feel like that's where people can tend to get lost in the weeds. We have to really make sure that the impairments that we're picking out are relevant to the patient, and they're relevant to us and the issue that we're trying to fix. Okay. Like if someone has a rotator cuff and a repair, and they're coming in, like previously, I should say, and they have some limitations. Is it something that needs to be addressed? Maybe that's just how their shoulder is at this point. And sometimes like we won't get that back.
So how do you, let's take that presentation, for example. How are you determining the relevancy of these supposed impairments in that case specifically? And we could talk generally as well, but how are you determining if an impairment's relevant, or how do you determine if it's a quote unquote impairment? It kind of goes hand in hand, but go ahead.
I think that for that, you have to take in the entire picture. There's a lot of context that comes into play, right? So if a patient comes in and they're telling me that, when I move my arm, like when I reach up on the shelf, and the shelf isn't at their available end range, but they're still having difficulty or pain with it, that's probably telling me that their mobility may not be the issue, right? Because it's not at their end range. It doesn't have anything to do with their restrictions per se. In that case, I would probably take a look at other things. So maybe how they're moving, their quality of their motion instead of their quantity. I might look at like their muscle activation and see like, are they actually recruiting like their periscap musculature? And if not, we can test it and see if that makes a difference. That's why I think that there's so much merit in the test-retest method. And I do it all the time. And Mark and I talked about this previously on other episodes. But when you perform this, especially on eval, you can really see whether or not you're going down the right path. Because if you're not going down the right path, the test-retest can usually tell you pretty quickly, depending on the deficit that you're looking to identify. Other times, you're going to have more complex patients. You're going to have trickier ones where even though your test-retest failed and there wasn't a discernible change, that's still the primary deficit that you're looking to address. And sometimes it just takes time. Yeah. And that's totally okay too.
Still information you can use, right? Like if you don't get the change right away, it's like, cool. All right. Maybe it brings you in a different direction. Maybe it doesn't. Maybe you're staying the course for a little bit more, but at least it's something you looked at. You have it documented. You have the patient knows it was looked at. It was assessed to some degree, and then the extent to which it was assessed, and maybe you revisit it later. Maybe it takes some more time. Maybe you have to do something different.
Yeah, and that's something that I had a lot of issues with initially. There were two main problems that I really noticed early on in my practice, which were A, needing to have test retest confirm what I believed their deficit was going to be, what their primary movement impairment was. And when it didn't line up, I wouldn't fully exhaust it because I was like, oh, well, this isn't showing it. But sometimes you really have to exhaust that impairment to make sure that it's either truly the issue or that you can finally rule it out. And if you haven't exhausted it with both multiple different methods or interventions, or with volume or with time and frequency, etc., you may not know whether or not that intervention is what they need or if that's the correct deficit that you should be addressing. And the second issue that I ran into was that when you are testing and retesting, you're constantly doing it. And until you know for sure where you're like, oh, I need to make sure that this is the right deficit. Sometimes you're not going to get that answer. You just don't get it right away. And that's okay. You know, like we always talk about how strength and motor control can take time to improve. Strength for sure. But motor control can definitely happen pretty quickly, but also sometimes it takes a little bit longer. And it's okay to not know for certain, but to then rely on your clinical decision making on whether or not you're going down the right path.
Yeah. And like conversely, maybe it's something that, you take the subjective, you get the information you have so far before going into your objective exam, and you think it's something, okay, hey, I'm going into this thinking it's something that's going to take some time. And you may be surprised if you test something, you do a certain intervention, you test, retest, and it's better. And then they come for a follow-up and it's better again, right? It's like, okay, cool. If you hadn't looked at that and if you weren't retesting because you assumed it was something that, hey, it's going to take, a certain amount of time for, these changes to happen, you're missing something, right? So you said, test, retest to roll in, we can use it to roll out as well, even in the cases where where we're assuming it's something that's going to take time.
Sure. And one of the other things that I think is really interesting that I found is sometimes your initial movement impairment diagnosis isn't the thing that needs to be addressed first. There have definitely been times where I address something and it ends up not producing the results that I want. And so then that leads me to believe, oh, this isn't what they need, but I may come back to this down the road. So I end up doing a different intervention, hitting some other deficit first to see if we can, for example, like if you, instead of taking a top to bottom approach, you do a bottom up approach, and then you may be able to make headway there. And once you start to make progress in that direction, you're kind of able to better understand the condition and the patient that you're working with, what exactly they need. So when you end up returning to that top-down approach, then you're better able to see, oh, now we're actually getting the changes that I want. It just wasn't the right time. We just needed to fix other stuff first before we make that change. And that to me has been really interesting to see. Just because I exhausted it right away doesn't mean that I need to completely rule that out, or I'm not allowed to reintroduce it, because a lot of times you'll get those effects, but you just need to be patient and you need to have confidence in your decision making and that it's sound. And so sometimes what you're seeing is the problem, but you just haven't gotten to that point yet. You haven't unlocked that level where you're allowed to make that change yet. So try to get all the other changes that you can. Whatever progress to me is good progress for the most part. And if things are calming down, that's already change in itself. And so when that happens, then you might be able to make something more impactful happen when you're able to address like the initial primary movement impairment that you gave for your patient.
Yeah, I think an easy example of that, I mean, at least that from our knowledge with MDT, we can see is if if you have a relative lateral component, but they also most likely are going to have impairments in the sagittal plane. Well, you're probably going to have to address the lateral, and then you're going to return sagittal. So you have a deficit in let's just say cervical rotation that gets taken care of. Then you go sagittal. You start the extension's been limited the entire time, but if we're addressing that first, there's something that has to be done before you address the impairments in the sagittal plane, right? So, like you said, we can identify our list of impairments, and use our knowledge to understand. Use our knowledge and then retest to understand. Okay, what's changing with what specific intervention, and then over time we can get an understanding of when it's appropriate to begin to address any kind of remaining impairments.
For sure. And for those who aren't as comfortable with spine or MDT, I think a really good example of this is like a cranky shoulder, right? Like if a shoulder doesn't move as well and it's painful during movement, do you have to restore range of motion first? And that's traditionally what we've been taught is if you improve their range of motion, that's when you start to work on the strengthening aspect of it. Because if you just strengthen before you get that range, you're pretty much strengthening through an incomplete range of motion. And in my experience, what I found is sometimes that's the case. Sometimes I'm able to restore the range of motion and it starts moving better on its own. That's fantastic. Other times I try to move them and they don't want to move. They guard. They're very apprehensive. It's really painful for them. And I give them a couple of like easy isometric exercises just to calm some things down. And then once their movement quality and what their available range of motion is, that improves, then we can start to improve on their actual like passive range and then their active range and stuff like that. And then that's how you kind of go from that top down and that bottom up approach to kind of kill two birds with one stone and make progress in that manner instead of just kind of force feeding one specific deficit that we need to work on right away. I think it's totally okay to pivot and take a different approach so long as you kind of know the things that you're taking a look at and when to revisit it. I think the hard part about doing things like this is just keeping things straight in your head and not muddying up the waters. Have a clear plan for when you're going to pivot and what you're going to do moving on down the road. I think that is what really separates people or clinicians because they're able to adapt to their patient's symptoms.
Yeah. So, like you said, I mean, things can get cloudy. We sometimes have a long list of impairments. Maybe prioritizing them in some way, or put it this way, I guess you can prioritize them based on what the patient, maybe the functional limitation is the biggest thing they're concerned about, but you also see, severe limitations in range of motion. It'll typically tie together. But like you were mentioning, retest is going to give you the best idea of, what you need to address when, right? Like you said, if you are applying a certain intervention, you're getting a quick, rapid change, it's lasting. Okay, you're riding that out. You're reassessing your other impairments, right? But even let's say you got 7 or 8 things you want to work on. Not that you necessarily have to take one at a time, but if you're making an improvement in a high priority impairment, functional limitation, whatever it is, you can know you're on the right track, right? The other things can come with maybe it's time, maybe, once the primary impairment begins to resolve, you can start to take a look at maybe some of the secondary ones. But yeah, kind of like you were hinting at there, like the retest is going to give you so much information on, where you're at in the process.
So you mentioned how you would prioritize things. Is there a list of impairments that you typically would prioritize over others, things that you're looking to make changes to first. Maybe they're more important to you. Maybe they're more important for the patient. Like what is the structure that you typically go through when you're trying to identify these things?
So what I have found I'll say prognostically, but maybe a better way to put it is the thing that gets, or I think the reason why it prognostically has the most benefit is because it gets the patient's attention the most, is if you're able to change their symptoms, primarily pain, maybe, if it's like a numbness, tingling, something, but if you're able to get a symptomatic response, if you're able to change a symptomatic baseline, whether it's at rest, during movement, to me, that seems to be the priority, right? Like we were talking about earlier in the episode, we talked about range of motion. It's a big deal, right? But if someone, let's say they still have a relevant range of motion impairment, but it goes from being like a 5 out of 10 to a 1 out of 10, that's really easy for the patient to sense. And also, they're going to, you kind of have your buy-in right away. Oh, look, this person, I did this movement and, my pain was reduced by 80%, right? Cool. They're going to know versus, oh yeah, I stretched my arm and it still hurts the same amount, but I moved it more. I mean, you might expect that kind of response from just moving, right? So for me, symptomatic baseline, usually pain is the primary thing that I look at. And then if they have a obstruction or restriction in the range of motion, do the pain. That's the next thing I look at. So let's say they do a certain movement, we have like a severe or moderate restriction in that range of motion. They do, whatever movement it is, and the impaired range of motion improves. To me, that's a good mechanical baseline that we can reliably reassess. It falls high on my list. And then if we're looking at top 3, the third one from there, probably going to be something like maybe like a secondary type test, whether it's like a Faber or Fader, or I don't know, let's say they had painful resisted movement, but some kind of something in that regard, something that we identified as an impairment, but it's maybe not the most easily reassessed thing by the patient. Like we talked about, like a clinician guided test or assessment, such as neural tension, or maybe, like we said, like a joint mobility test, something like that. I mean, it's still something that we can reliably reassess, maybe not something that's as noticeable to the patient. So it falls a little bit lower on my list. But yeah, I'd say pain or whatever symptomatic baseline, range of motion, and then the kind of clinician guided assessment test fall behind those two. Do you look at anything different? Do you have anything that you think gives you the best value if you're able to change?
Yeah, so I think that first part is very, very high up on my list. Like if they have resting symptoms that we can change, that definitely is a big deal to me. I think the second thing that we kind of talked about is like their function. Obviously, like is their range fine? They can check that. They know that. Is their strength changing? They know that. Like if they're reaching and moving things, like they're going to feel that. That is definitely a component of strength that doesn't require me to test them at all. And I think that the last part that you mentioned, which is like anything that I need to do to derive information from, I just don't find it to be nearly as helpful or useful, because some of the things that we do are just going to be provocative. If you put a lot of people in a Faber or a Fader, they're going to have pain.
It's meant to have a symptomatic response. Yeah, exactly. Or maybe the person wasn't even, how do we know if it's relevant? If maybe, chances are the person wasn't, hitting themselves with a Fader throughout their daily tasks, right? I mean, it's, it could be what's just called a coincidental finding, right? It was there, we assessed it, and they had pain, but like, does it is it relevant? I mean, in this case, maybe not. If they had other kind of, if they had baseline symptoms, yeah, let's use that as their guide. Why do we have to like crank their hip to determine? Yeah, I don't think we get more value from it. Yeah, especially if they had baseline symptoms.
Yeah, for sure. And like if you take fader, for example, you're just shoving the femoral head right into the hip joint. So it's like it's gonna be
feels great.
Provocative. And the other thing is some patients don't know what that's supposed to feel like.
Mm-hmm.
If it's tight, they may perceive that as, oh, that's a symptom, in reality that you're winding up that tissue. That's going to happen. So that to me just lends itself to false positives that you don't really need to muddy up the waters any further. I still check it if it's a structure that I need to assess, but if it's something that I'm trying to compare my baseline to or like my intervention to, then I don't know how much weight I would really put onto it.
Is there a situation where? Sorry, go ahead, finish, and then I got a follow up for you.
Oh, I was just gonna say, if that is my only comparable sign, and they have nothing else, I honestly would just say that's okay.
Yeah,
when are you putting your hip in that position?
Yeah, that was my question. That's where I thought you were kind of going there. So let's go. Is there a situation where you would use that? Like, what if that's your only baseline? What if there's nothing else? No kind of range of motion limitation, no strength limitation. They don't have any. How should I put it? Maybe it's a day where they don't have pain. They have pretty intermittent pain. They have good days. They got bad days. They're in for their eval. Let's just say a fader produces the same kind of symptoms they get. Do you find in that case that, the test is going to give you more value compared to a different presentation where the person had baseline pain, they had range of motion limitation? Does it change how you assess it? Or is it just, okay, yeah, this is my baseline, this is what I'm working with, I'm going to reassess it and, use it as my baseline as any other kind of baseline or symptoms that they have?
Like, I'm going to address their baseline symptoms first and foremost. That's my number one priority. Because if they're coming in and they're having issues like all the time, or it's like pervasive in their day-to-day life, I'm for sure going to see if I can make a change there faster. Because if I can make that change, prognostically, I think it's just a better indicator for how they're going to do.
Yeah, and you say change, it doesn't even like. Regardless of not regardless of what the change is, but like, let's just keep using fader. No other impairments. They had pain with this. You reduced the pain. You got rid of the pain. That's still to you just as valuable as if they had baseline symptoms and you had the same degree of response to baseline pain.
I wouldn't say that. No, if we just used a provocative special test, then I don't put nearly as much into that, just because, like we said, it's supposed to be provocative. But if it's like their normal baseline pain, and I'm making a change there, that means a lot more. Now, the question is when you have a patient that comes in and they say, oh, I just get this pain randomly, I don't know when I feel it. You take them through all of your testing and you find nothing. And then maybe they have one specific motion that creates it. And then you end up doing fader and then you end up getting a positive test. Then you're like, okay, that recreates your pain. But at that point, is it still relevant? And that's where I think that's really hard to actually determine that and using that as a comparable sign. There have definitely been times where I've used it previously as a comparable and gotten completely lost because it's just happening over and over and over again. And in my head, I'm like, what was their hip like before this? Was it provocative before this? Or am I just chasing my tail in a big circle?
Yeah, it could have been. Yeah, that test could have been quote unquote positive for 5 years, but then now they have a symptomatic presentation that's like 3 months old, and you're putting a lot of value into this test, and maybe it's not relevant. Yeah. Now, retest is going to give you a lot of information there, right? If it's not changing, it's staying the same. It's provocative to the same degree, regardless of the kind of movements you're doing. But how are you? How should I put it? If otherwise they're asymptomatic, like is there, in terms of determining the relevancy of that specific quote unquote impairment, and then in terms of, when do you stop looking at that? When do you start to try and tease out other things?
So I was actually going to ask you the same question.
Okay, you want to? Yeah, go. Okay, you first.
This is a tough one, you know? So
yeah.
I've definitely seen it in the clinic where, for myself, I have a patient where they're like, I don't know when it comes on. It just comes on. Yep. I take them through their full physical exam and I can't really find anything. And so at that point, I just start cranking away. I'm going to test them to end range. I'm going to test their strength in a bunch of different ways. I'm going to load them. I'm going to check how they're moving and stuff like that to see if we can reproduce it at all. And if there's no reproduction of it, that to me is a whole lot harder. So I actually had a gentleman come in a couple of weeks ago, actually. And he said, my knee buckles. I don't know why it happens. It only happens with stairs, and I can't find a trend with it at all. He's like, there isn't it's not due to activity. It's not due to fatigue. It isn't time of day. It isn't the amount of reps. He's just like, it's just that when it gives, it just gives. And that's it. And I checked everything. I checked his range. Everything was good. Moved super well. I checked his strength, which was fine. He wasn't like remarkably strong, but he was like strong enough for an average person. So that to me was not the issue. Checked his hips, checked his back, checked everything. I was like, I cannot find a single deficit. I have no idea what. Like if I had to put it on one thing, that this was like his main impairment, I just didn't have it. Right. So what I told him to do was I've had a whole lot of success in regards to knees and doing repeated knee extensions. So to me, the way that he kind of described it, the way that his knee was giving out, seemed like it could have been more of a joint issue. I don't think that it was like a muscular issue. He was strong in all of his stuff. I couldn't reproduce any of his things when we were
characteristics are leading you to think could be joint?
So,
or even let's say characteristics, but yeah, I mean, even if you want to talk about it within the context of today's episode, impairment wise, but I think even just speaking about the subjective information, building on last episode, yeah. So, what's making you think joint?
So, to me, it was just the fact that his knee is giving out, and causing significant amounts of pain, specifically at like joint line for him. So he was someone who was in his 50s, around there, 50s to early 60s. And to me, it could definitely be joint. Could it be meniscal? Sure. Could it be OA? Sure. Like these things can happen. I've had patients where they have OA and they're like, my knee buckles like that because it feels weak or it just doesn't feel strong or stable or anything like that.
So you have that local joint line pain. It's variable, intermittent, right?
Yeah. Cannot reproduce it at all. And so I went with what was the clinical pattern that I typically see, and I gave an intervention. Even though I couldn't find anything, there was nothing else for me to go off of, I gave him repeated knee extensions. So he first did it and he didn't notice any change. We were able to get him to have his symptoms when he was going up and down the stairs. I made him go up and down the stairs 10, 12 different times. And then all of a sudden he's like, oh, I feel it. It happened right there. We tried it another 5, 6 times. Nothing. Couldn't reproduce it whatsoever. And he's like, sometimes it happens a lot. Sometimes it doesn't happen at all. And so I sent him home with his repeated knee extension. And he comes back the next visit and he's like, oh, it's not giving out to the same degree. The pain isn't quite as much. I'm not buckling all the way. I'm buckling 75% of the way.
And how long had he been having these issues? the buckling?
I think he had it for just like only a few months,
Okay.
like three months or so, maybe 3 to 5 months, and before he really noticed, like, okay, it's consistent, it's not going away,
Okay.
and that's why he wanted some
Yeah.
help.
Yeah. Okay.
So
So
after. I was just gonna say after his first follow up, that's when he was like, okay, I feel like 75% of a buckle. I can feel it coming on more, so I can kind of control it. And after the next visit, he said, "Oh, my buckling hasn't buckled at all this week." He's like, it feels completely back to normal now. And so I want to make sure that it's just his knee and that there's nothing else going on. So I want to continue testing it a lot further, pushing it to see if we can get any other symptom reproduction, if it happens any other time. If it's just the joint, that's awesome. Super, super easy fix, as you can see, right? And this is why I love repeated movements, is because when you find that directional preference, it just goes away. Like your job is done within the first like few sessions. But the other thing is just making sure that we're doing our due diligence. Just because we found one impairment that seems to have fixed it, it doesn't mean that we just skip over everything else. We still need to test and make sure that he doesn't have anything else going on, that everything else is actually resolved.
Yeah. So like quick recap of that case then. Someone came in, they have their chief complaint, knee buckling. You don't see a ton impairment wise, right? Maybe you don't see like anything, or at least in the first visit aren't able to identify anything. Even when we have these presentations, you can use your background clinical knowledge to apply some kind of intervention, right? So you determine that within the session you weren't able to change it. Okay, maybe it needs more time. You say, okay, maybe you've seen this presentation before. It's you're talking about buckling on the stairs. It's essentially repetitive loaded knee flexion, albeit it's not end range, but you can still, how would I counteract that? Okay, let's have them do knee extension. Maybe that's the loaded flexion repetitively is something that's causing the buckling. You apply the intervention over time, you follow up. He's telling you it's better. Okay, cool. Let's stick with it, ride it out. Okay, now it's gone, right? So, I guess this segment of the episode, or something we wanted to achieve through this episode is trying, even when you get someone who comes in and it's really variable, which the variability, is a pretty hallmark sign of some of these presentations. Like you can still use your test retest within the session. If it doesn't change, then maybe it needs a little bit more time. So you're using that background knowledge, you're using your clinical skills to still apply an intervention. Okay. And then it's just assessed over time. What else? Anything like regarding that case that you learned that you applied going forward in the context of identifying impairments?
I don't think so. I think that it was just so interesting because, like I said, I couldn't find any impairments. I pretty much checked him from his spine on down, and everything was good, no issues. And so the biggest takeaway for me is sometimes you just have to rely on your clinical decision making and your pattern recognition, and sometimes we have to give them something to see if we can make a change. And if we make a change, that's awesome, right? Like this is, we made a change quickly and it gave me that hint that we're moving in the right direction. If we don't make a change, that's okay too. It just kind of tells us that, maybe it needs more time or that we need to do something else. But don't be afraid to give an intervention, even if you don't know what exactly is going on. Yeah. It's okay for you to figure out things because like a test in itself is going to give you more information. You don't need to have that answer before you apply something. These are all experiments at the end of the day. Yeah. But
the patient isn't going to, at least in my experience, if you're upfront with the person, like we don't have to lie to them. Tell them, hey, listen, we did a bunch of stuff today. We weren't able to change anything. I'm not seeing a lot when it comes to, stuff we can address today, it's a single snapshot of their entire week. They're for 45 minutes to an hour. They have the entire rest of their week to test things under your guidance to get a clearer picture, right? So, at least for me early on, if people came in and nothing stuck out, I'd give them essentially what was random exercises. And the person kind of understood, oh, well, you told me that there wasn't a lot going on, but now what do I have to do these exercises for, right? Where if we frame it differently, hey, I need more information. This is what I'm going to have you do, and then we're going to see what happens over time, right? That's a way that we can expose or identify these impairments outside of the time that we have with the patient. Like I said, you get these people coming in, there's not much sticking out. It doesn't mean that you can't help them. It's just you need more information, a little bit more time, and it needs to be tested farther.
Yeah, and I think one of the other things that I try to do a really good job of is my patients see when I do test retest. I explain it to them and tell them like, hey, we're going to be doing this a lot because I want to make sure that if something changes that we capture that and that we know that something has changed. And so with this gentleman in particular, I told him, I was like, okay, we're not seeing any changes right now, and that's okay. I want you to go home. You saw exactly what I did, right? Like you saw me go through the stairs, and then after I'd apply an intervention and I'd have you go up and down the stairs again and double check. And so one of the things that I think is so important is teaching our patients how to assess their impairments and determining whether or not the intervention is actually working or if it's plateauing or anything like that. Because then they're able to see, oh, I did this before and it flared me up. So I'm going to apply the intervention. I'm going to try it again and see if it still bothers me. And then afterwards, can I do the intervention to help manage my symptoms following?
So you're preparing them to understand why what they're doing, excuse me. You're preparing them to understand, the process, what you're looking for, what you're expecting to happen, perhaps, or at least what you're looking at, and if you get a certain response, what they should expect to happen in the future and how they're able to assess that on their own.
Yeah, so I pretty much try to teach them to be able to self-assess and evaluate their own symptoms, know whether or not something is working, right? Because a lot of times, like if I'm making that change in the clinic and I'm making it rapidly, I'm like, no, this is what you should be feeling when you're at home. Yeah. It shouldn't change when you're here versus when you're home. Yeah. Exactly. So if they're able to do that, then they can come to me with way, way more information. Then they're like, okay, I did this and I didn't have any pain after I did the exercise, or it flared me up and I did the exercise and it completely went away. Awesome. Mm-hmm. Now you just gave me a whole lot more information, and they're going to repeat this pattern for everything that they do that's provocative, because now they understand that fundamental concept. And now they're starting to think in a similar manner as how I would when I'm problem solving. And so I'm essentially using them as an extension of me at this point to help bring me more information. Like, I think it's so funny because whenever I treat spines in particular, I always tell my patients, like, I function as an interpreter for your symptoms. Like, your body is trying to tell you what it wants, and it's my job to kind of figure out what exactly that it's telling you, what it needs. And it's my job to then give it what it needs and to be able to teach you how to interpret it and then to keep your body happy. It's not like I'm giving you a cure or anything, but I need you to help me, like we're a team, to be able to give me that extra information. And so I try to teach them how to derive that information and then how to test it and then convey it to me so that I can make the best decisions for them moving forward. And I tend to do that for a lot of patients that I treat now, because then they see it much more as a collaborative effort that they're helping me help them.
Yeah. Another way their expectation is, hey, I'm going to go to this person. I'm gonna, they're gonna ask me to do stuff, and then based on information I give them, they're gonna help me. Rather than, oh yeah, you just show up, you do your exercises, you leave. Next time you come in, how you feeling? I'm okay. All right, let's go to the bike. Like, right. I mean, it's a completely different experience. It's not,
Yeah.
I think even regardless of the outcome, people appreciate it. They feel
there's
more
much-
heard. Yeah, it's you're on the same page. Like you said, it's collaborative. You're on the same team.
Yeah, and people definitely appreciate that so much more. And I think that it really helps tie in to like what their expectations are, because I can help teach them what exactly like we should be looking for, how much change can we be looking to make here, instead of kind of just like stringing them along. Like I don't want that to be the case where a patient comes in like, yeah, I guess I'm getting better. Oh, okay, yeah, let's just keep going with it. And that to me is just like something where if we're not on the same page, they don't feel like we're on the same team, then it makes it a whole lot harder. And for patients we're PTs, we don't have 100% success rate. You're going to have patients who you cannot completely resolve their issues. When I can't completely resolve them and they see the process that we've gone through, they are a lot more appreciative of the things that we've done and the progress that they've made, even though they haven't resolved. And sometimes it just takes time.
Yeah. I had a guy last night. There's nothing like, I think my words to him were, so I'm for 3 visits. Nothing's changing, right? Okay. So something else has to be done. But I think my words to him were, hey, listen, I mean, come 3 times. We haven't been able to make really any kind of change in your symptoms. We've exhausted every kind of movement or really like intervention possible. Like, I think, you need to explore other options. And he's like, yeah, I completely agree. He's like, and he thanked me. I was like, I'm sorry I wasn't able to help you. But he's like, no, like now we know this is, we went through everything. Like, I mean, test every kind of movement possible for the guy's shoulder. Just nothing changed, right? So he's able to see, like, hey, he goes back to the doctor. I was like, hey, I went to PT a couple times and they really tested me out. And it's just like nothing happened versus, the perhaps standard of care. Oh, you're going to come 2 times a week for 8 weeks and you're going to do your routine. And then at the end you ask them, oh, well, you think it helped? Or, 0 to 100%, how much have you improved? 0, right? Well, I mean, you're asking that question after 8 weeks. I mean, you could have figured it out a while ago, right? Maybe it's something that takes more time, but just based off knowledge and experience, I just don't think it's something that's going to respond. But yeah, like the people are appreciative of this kind of process. It almost seems like regardless of the outcome, they can see that you're interested. They can see that you are, motivated, as are they, to be able to, help the person.
You're back.
We're back. All right. Where did I stop? Where did it cut out? Where did it cut out?
You were talking about when you see a patient and you can make a change quickly, and you're checking in on their Grok score versus
okay.
like
so
checking
that was,
it like
that was basically at the end. Yeah, like let's say we talked about the case I was talking about. A couple of visits. I just know this guy. He's not. We did everything right. He understands. Listen, I can tell you're testing everything. You're asking me how it feels after, right? This is, I don't think PT's the right option, right? Versus, maybe the standard of care for this presentation is you come twice a week for 8 weeks, and you just come in and you do your routine. At the end, it's like, okay, time to do the measurements, time for the reassessment. Oh, 0 to 100, how do you feel? Oh, it's 0. It's been the same the entire time. I just think we arrive to a conclusion quicker and more efficiently if the test retest is implemented on a consistent basis.
I 100% agree.
Like I said, regardless of the outcome, the people seem to be appreciative of this kind of process. This at least this management strategy.
Sure. I definitely agree. I will say that there is a downfall to this, and it is one that I have fallen prey to, which is sometimes when you retest and you're not making that change, I sometimes, as much as I try to stay patient now, is that when I'm not making those changes, am I giving up too quickly? Have I exhausted my resources? Have I tried everything that I could? And this is something that I feel like a lot of physicians will give pushback on, where they said, I said 6 to 8 weeks of PT, and
Yeah.
then now you're
Yeah,
saying
yeah.
them back to me. And so to me, like, it depends on your relationship with that physician. Especially for spine, I expect to make changes fast. Like, if I can't make changes fast, symptoms aren't changing, or they're worsening, that's where I'm like, hey, this isn't something that I can treat right now.
Yeah. Yeah.
And
Right
that's
now,
okay.
right?
It's
Maybe
just,
in the future, maybe they need something else to calm it down. They come back, reassess. Hey, now we're getting changed, right? Not like, oh yeah, PT's never going to be the answer for you, right? Or at least like movement based approach isn't ever going to be the answer for you. But like right now, this moment in time, it's probably not the best option, right?
yeah, and I feel like as I've gotten better with that, I'm able to have those conversations with patients a little bit easier, where it's like, hey, I can't make this change. Like, these are your symptoms right now, and this is why I can't do that.
Yeah.
When things change, then I can make something happen. But I've had a much easier time and a lot more confidence being able to express that to my patients, even though I want to fix them, right? I want to fix everyone
Yeah,
as best
yeah.
as I can. But there are some things where you just have to know your limits. And when you know your limits and you refer them and get them to the appropriate provider, they're going to be so much happier because you just expedited their process.
Yeah.
Like,
yeah.
they don't have to be in pain for as long. And that, to me, I think is something that is a very underlooked skill as a PT. It takes a lot more time, more finesse, a lot of reflection, and also just knowing, like, okay, I've done what I needed to do. I can't do anymore.
Yeah. And I don't think that, like you said, that knowing your limits, I just don't think that skill is, I don't know how teachable it is besides through utilizing a system that has emphasis on test, retest, and knowing and identifying with a standardized treatment and evaluation, treatment and reassessment tool, utilizing that consistently enough to understand presentations that just maybe aren't going to respond to physical therapy, that may need something else, and then knowing when to refer.
All right, so I think that kind of ties up everything that we wanted to discuss for today's episode. Mark, is there anything else that you want to add?
No, not too much. I mean, I think this certainly builds off like we talked about. You're getting when it comes to identifying impairments, measuring them, and determining if they're relevant. You get some information from your subjective. You get some information from the objective, and then you might have a list. You may have 7, 8, 9, maybe 10 plus impairments, but like we talked about, it seems that the value in the impairments has a positive correlation with the relevancy to the patient. So we're looking at their pain having having a high value, their functional limitation having a high value, and then range of motion, right? Things they can easily assess. Seems like things that they know, or things that they can notice have a quick change. Teaching them how to reassess on their own. We talk about they can easily reassess those 3 things. And then, once you begin identifying these impairments, demonstrating an understanding, or at least managing their expectations in regards to how they can expect these kind of impairments to change over time, are some key things to focus on when you're looking at identifying impairments. And then one last thing that we talked about, reassessing in the clinic. The patient should be able to reassess on their own as well. This is something we're going to talk about in a future episode when it comes to formal appointments for reassessment, how the patient's able to reassess on their own. Okay, so the next episode we're going to talk about is going to be focused on treatment, different treatment styles, different philosophies, maybe different kind of presentations that certain treatment styles best address. And then, of course, we're going to be tying it back to our test retest that model, how it fits into different treatments, how it fits into different treatment styles and philosophies. So thank you for listening, everyone. We hope you enjoyed this episode of the PT Good podcast. Remember to leave a like and subscribe to us on whichever platform you're listening to us on, and we'll see you on the next episode.
Still love you. Bye.